talk about musculoskeletal problems, fractures, osteoporosis, osteomyelitis. First aid, if you stumble across somebody that's been hurt or you yourself have been hurt with trauma or a fracture, or you think it's fractured, use the Rice method. So you want to rest the limb, you want to use ice and immobilization, and you want to use compression and elevation. Um, then use ice for the first 72 hours, and then after that, you might try some heat. And then your patient teaching for the frequency of ice, or if you're in an accident, you should never put ice on continuously. You want to do it every 2 hours for 10 to 20 minutes at a time. If you come across somebody who has a compound fracture, now a compound fracture means it's an open fracture, like the bone has pierced through the skin, so the skin is open. You are going to immobilize that limb. You are not going to try to put it back into place. So we call that splint as the leg lies, or splint as it lies, okay? The 6 P's of neurovascular assessment. Okay, or compartment syndrome. So we do monitor the 6 P's of neurovascular assessment, because when a patient has a limb injury like a fracture or they've had surgery, we want to make sure they're not developing compartment syndrome. And the hallmark of compartment syndrome is that the pain the patient describes is out of proportion to what the pain should be or typically is, and it's unrelieved with pain medication. So we're going to assess for pain, and that would be, they would have pain because the limb is ischemic. The limb could be pale. So we always check the circulation and color. We check the cap refill too. We want it less than 3 seconds. We check for pulselessness. If you can't feel a pulse, get a Doppler. If your organization doesn't have a Doppler, one thing you can do is put the O2 sat very carefully on the big toe and see if it gives you a waveform. If it does, the patient probably has a pulse. But if it's a change in condition, like the patient had a plus two pulse on the last check, and now they don't have a pulse, that's a call to the provider, okay? And you would check a Doppler too. So you could report if the Doppler was hurt or not. Okay, paresthesias, that you're going to ask about numbness and tingling. You're going to ask about paralysis, or actually ask them to wiggle their toes. And then poikilothermic means that the limb could be very cold to touch. Okay, so we check the temperature. All right. Now, casts are an option for fractures, and it's used to stabilize a closed fracture, not an open fracture. The nursing interventions, when a client has a cast, now you're going to have to know this because this is important. So you're going to assess for heat as the cast generates, because as it dries, it's going to generate heat, and it could cause burns, and you don't want your patient to be burned. You're going to ask about the cast matter. Fiberglass casts dry very quickly, like 30 minutes. Those are the cute, usually the fluorescent ones are really cute. Plaster of Paris takes forever to dry. That's why you would ask what kind of cast it is. You want to elevate the extremity to minimize sweating and prevent swelling and prevent compartment syndrome for 24 to 48 hours after the incident, okay? Or after the cast was put on. Hold the cast with the palm of your hands and do not use your fingers. If you use your fingers, you could put indentations into the cast that can then, tweak their skin underneath. All right. Burning pain could mean the start of a pressure ulcer. So make sure the cast is supported. So you're going to elevate it on pillows, right? If no improvement after repositioning, notify the surgeon. They can do a window. They cut out a piece of the cast so that they can see the skin underneath. You want to make sure the cast is not going to cut off circulation, and you want to make sure it's a proper fit. So one finger, not two, one finger should fit between the cast and the skin, okay? You want to tell the patient not to put sharp objects to scratch under the cast. They can take a 60 ml syringe and put air in it and push it through the under the cast, and they can also use a hair dryer on a cool setting to relieve itching. You never want to put a plastic bag of ice over the cast. You want it not on top of the cast. You want to put it like against the sides of the cast, okay? Because you don't want to put pressure on the cast. Trapeze bars, yes, every orthopedic bed should have a trapeze bar to promote independence. All right, the dry cast is white and shiny and resound when tapped, okay? A wet cast is gray and dull, and it gives a dull thud when tapped. We talked about elevating the limb, and remember that prolonged immobility can lead to disability from frozen joints. So that's why we want to do range of motion, okay? How often should the nurse check neurovascular status? After trauma, fractures, any orthopedic procedure, vascular procedures, any procedures on the limb, you want to do them every hour times 24 hours. Then after that, you can go to Q4 hours if the patient is stable. Nursing management of fractures. So pain management is very important. Now, if you medicate somebody and the pain isn't relieved in 30 minutes and the pain seems to be way out of proportion to what the patient's injury is, you need to notify the provider because they could have compartment syndrome. All right. Anybody that is, has had trauma, has a fracture, or is going to need surgery, or going to be immobile, is going to be at risk for constipation. So they need to drink a lot of fluids, eat high fiber foods, and avoid cheese and milk and dairy. That can cause constipation. Range of motion. So we do range of motion to prevent contractures, not to strengthen the muscle. And then the type of range of motion you would perform on a patient with flaccid paralysis would be passive range of motion. You should change the joint position. Anybody that has flaccid paralysis, change the joint position frequently too. Okay, that's to prevent contractures. All right, now, preoperatively, the provider may want skeletal traction for skeletal traction would be used to maybe try to reduce, and reduce means fix the fracture. That term used to really screw me up. So they would put a pin into the bone here, right below the joint, and then the traction weight would pull the bone down a little bit, okay? So the pin is going right into the bone, and that's going to put them at high risk for infection. We don't use this as much as we used to, but sometimes it still gets ordered. What should the nurse do if the pin site looks infected? Get a culture. So there are pin sites on here, and you have to do pin care. Usually it's once a shift, and you use a Q-tip, and you only use one per pin, and you're going to look for signs of infection because that's what you're worried about. And you never use betadine, which is iodine solution on pins. All right, now the other type of traction is called skin traction, and there's no pins going into a bone. It's just done with bandages and moleskin, and it's applied to the skin, and the weight pulls the limb a little bit, and it's usually used. It's Buck's traction is a kind of skin traction, and it's usually used before surgery after somebody like fractures their hip, and it's to reduce the muscle spasms and make them more comfortable while they're waiting for surgery. Now, some of the nursing implications about traction. First of all, you're going to check the patient's temperature if they have skeletal traction frequently, right? Because you're worried about osteomyelitis, which is a bone infection. All right. You're going to check the ropes. You want the ropes to hang freely, and you want to make sure they don't have knots in them. The alignment of the extremity you want to maintain. Check the setup and assess for swelling. Circulation, check for the 6 Ps. You're going to use a trapeze, or the patient should have a trapeze so that they can move around, that you can move in traction. You want to increase their fluid intake because they're going to be, they're at risk for constipation. Trapeze again, okay? No weights on the bed or the floor, and do not release once established. In other words, the tech or whoever does the traction is going to apply it. After they apply that, you don't move the weights. You want the weights to hang freely, not resting on the bed, not resting on a table. You want these to hang freely. The patient's foot needs to be free, like it shouldn't be up against the footboard here. And see, this is nice. The heels look like they're off the bed, okay? Because the patient can get foot sores, and you need to check the skin under this splint, okay, the traction splint frequently, so that because the skin can break down, and you're going to check for the 6Ps every hour while they have this as well. The patient can move around while they're in Buck's traction. You can put them on the bedpan. It can be intermittent, so maybe they'll be able to get up and go to the bathroom. So that's basically Buck's traction. Traction care. Keep the patient in the center of the bed, and you want to keep the parts in traction in a straight line with the trunk. Check for the 6Ps, right? Make sure the weights are hanging free. Don't adjust the weight, so don't put more weight on it. And don't put a table under it. They need to hang free. You can pull the patient up in the bed without lifting the weights. Don't let the feet touch the footboard because it's going to defeat the purpose of the traction. And make sure you're checking the skin, Q2, and examine the skin under the traction splint. Make sure the ropes and slings are not pressing into the skin and there's no knots in the ropes. And do not use povidone iodine, which is Benadine, for pin care. Pin care is done Q-shift, and it's 1 Q-tip per pin. You're basically just cleaning around where the pin comes out of the skin. So the potential complication of skeletal traction is osteomyelitis. Okay, and you would also worry about osteomyelitis with an external fixator. So it's all the same interventions. You're going to do neurovascular checks, Q1 hour times 24 hours, and then Q4 hours. But you would check these pins. You can't really see the pins. I know you can see the fixator. You would never use this fixator to like pick up the limb. Okay, don't use it to your advantage that way. Okay, you want to just let it be and clean the pins, and you can elevate too as well. All right, so osteomyelitis, it's a bacterial infection of the bone. And people that have like external fixations and like skeletal traction are going to be more at risk. Of course, open fractures, definitely at risk. So the signs and symptoms: sudden onset of severe and intense pain, marked by tenderness at the site, fever, obviously, high fever with chills, swelling of the skin, headache, and malaise. So it's not fun. And it takes a long time to treat it, like months and months of IV antibiotics. So you want to try to prevent this at all costs. Okay, compartment syndrome. I talked about it a little bit. It's some pressure that restricts circulation in one or more of the compartments of the extremities. So these are the different compartments of the extremities. So the skin is around it, right? So if one of these compartments swells, there's only so much the skin can expand, right? So they're going to get compartment syndrome. So that's going to decrease their circulation, okay? So again, the hallmark is severe, unrelenting pain, unrelieved by narcotics. So you are going to assess the 6Ps. Call the provider if the patient has pain that is unrelieved by narcotics. Now, to prevent compartment syndrome, you're going to elevate the limb. If you suspect your patient has compartment syndrome, put the limb down. Do not elevate the limb, okay? Put it neutral with the body. So fat emboli, I'm going to talk about this in the pulmonary lecture, but just a long bone fracture like a femur, maybe the pelvis, these kind of bones can result in a fat emboli because the fat leaks out of the bone marrow and can travel in the bloodstream. And so it's just the same signs and symptoms of a pulmonary embolus, right? So tachypnea, the patient's sudden tachypnea, shortness of breath, tachycardia. And the hallmark kind of a fat emboli is the petechial rash. So they'll have petechiae all over their chest and axilla and neck. They'll have a temperature and a feeling of impending doom. All right, osteoarthritis is a non-inflammatory degenerate joint disease that can affect weight-bearing joints. It's not symmetrical like rheumatoid arthritis, and it affects only 1 to 2 joints on one side of the body. And these are what their hands look like, okay? Little bit different. Remember, with rheumatoid arthritis, they had that swan neck deformity on their hands. So the risk factors are being overweight, aging, having joint injuries and previously, and then repeated stress. Okay, so the signs and symptoms of osteoarthritis include outgrowths of bones, so bone spurs in the joint, stiff joints. It limits their ROM. Many people limp who have osteoarthritis, especially if it's cold or they overuse the joint that day. They'll have tender joints. They can experience crepitus with movement. So sometimes when I move my shoulder, I can hear crepitus. It's like creaking in my shoulder. And it's only joints. It's not systemic like rheumatoid arthritis. So the signs and symptoms: pain, stiffness, limited range of motion, and limping. Nursing management, you're going to encourage the patient to strengthen their muscles and engage in aerobic exercise. They need to, engage in weight reduction if they're overweight, because that puts stress on the joints. You want to maintain joint function. You want them to meet performance goals like exercise goals. So put that in the care plan. Balance exercise and rest. Help them with moist heat application because that feels good on the joints, and encourage them to maintain weight in normal limits. Okay, a total hip replacement. Total hip replacement, or total hip arthroplasty as it's known in its formal name. This is the surgery with the highest risk of DVT. So they are definitely going to be, or they need to be, on some type of DVT prophylaxis, okay, from the get-go. You're going to monitor for infection at the site, monitor the H&H. That surgery is quite bloody. Monitor neurovascular status, the 6 Ps. Actually, it's Q1 hours, not 2 to 4, Q1 hours for the next 24 hours. And then it can be Q2 to 4. Administer the anticoagulants for the DVT prophylaxis. Monitor the drains. They usually have a hemovac with a hip replacement. Transfer out of bed from the unaffected side first. And surgeon will tell you what kind of weight bearing the patient is allowed, whether it's full weight bearing, partial, and they work with physical therapy to get up for their first walk. They need adaptive devices and ice to the surgical site following ambulation, definitely. So you would ice it for like 10 to 20 minutes every 2 hours. Total hip precautions include keeping the patient supine with the head of bed slightly elevated, keep the affected leg in a neutral position, the pillow or abductor pillow in place, especially when turning, and also discharge teaching is important, which I'm going to get to. Now, because of this abductor pillow, they're at risk for decreased circulation because of these straps. Okay, so you want to make sure you're assessing the skin, but also the 6 Ps, because they could have alterations in their peripheral circulation. All right, hip replacement discharge teaching, very important. Patients need to know it's okay if they lie on the operative side. For 3 months, they cannot cross their legs. They do need to keep a pillow in between their legs if they're in bed and they want to roll over to their other side or lie on their side in the bed, right? Because you never want the leg on the side the surgery was done to adduct. Adduct means move in, okay? You don't want that. And it's okay to bend their hip, but not beyond a 90-degree angle. So you have to demonstrate that for patients. Avoid sitting in low chairs Always use elevated seating in toilets because if they have a low chair, they're going to go past the 90-degree angle. Um, so that's important. You continue the daily exercise program at home and make sure the toes are externally rotated. So externally rotated means the toes go, like the big toe goes out, okay, not in. You want to avoid flare. Flare is a mnemonic, and it stands for flexion. So you don't want to flex the hip beyond the 90 degrees. Adduction meaning you don't want the leg on that side the hip was done to move in towards the center and touch the other leg. Internal rotation. So you don't want the toes to go in, so like point inward, okay? So you want to avoid that. Instruct the patient to use shoehorns, dressing sticks, and always have raised toilet seats. And when they go to public restrooms, they have to use the handicap. All right, now we're going to talk about osteoporosis. Do not get osteoporosis confused with osteoarthritis. It's very easy to do. I do it all the time. So people that are at risk are female sex, postmenopausal females, 50 years old or older, people who smoke and drink, people that are small. So this is one condition that happens in skinny people, right? So people that are less than 127 pounds, white or Asian race, early menopause, sedentary lifestyle. They're not getting enough exercise. They have low vitamin D levels, so they're not getting out in the sunshine, and they have an insufficient intake of dietary calcium. So the best type of exercise to help prevent osteoporosis is weight bearing. So standing exercise like walking, running, weightlifting, okay? Those are good exercises for osteoporosis. Now swimming is a good exercise, but it's not weight bearing. So it's not a good exercise to help prevent osteoporosis. We're going to talk about amputation in the vascular lecture. Okay, so that does it for fractures and orthopedic surgery.